over time, although the number of CABGs performed in the U.S. has decreased over the last 2 decades, the proportional representation of cancer patients has increased concurrently over that same time period. And although there has been an increase, there's really no difference in mortality amongst cancer patients versus non-cancer patients treated with CABG, as within this analysis. However, there is some suggestion of an increased risk of bleeding and some increase in stroke, along with cost of care amongst cancer patients. Good morning or good evening, wherever you may be. My name is Daniel Addison. I'm excited today to help present this work published here in the prestigious Mayo Clinic Proceedings focused on coronary artery bypass grafting in cancer patients within the U.S. and our contemporary experience. At this point, I will allow my prestigious colleague, Dr. Aviroop Guha, also with our cardio-oncology program, to proceed as well.
Thank you, Dr. Addison. Hi, this is Dr. Aviroop Guha. I am an assistant professor of internal medicine with Case Western Reserve University, with University Hospitals, Haddington Heart and Vascular Institute. So the topic of this paper was coronary artery bypass grafting in cancer patients, prevalence and outcomes in the United States. We used the dataset called National Inpatient Sample Dataset from 2003 to 2015, where we analyzed the trends of utilization of coronary artery bypass grafting, or CABG, in all cancers, some specific cancers, and then metastatic cancer, and then those who received inpatient radiotherapy. We did some propensity matched analysis for contemporary practice to compare outcomes. We noted that the overall comorbid cancer increased from 7% to 12.6%, but overall CABGs have gone down. The commonest cancer in the groups of cancers was prostate cancer at about 30%. And we did notice that the in-hospital mortality after accounting for everything remained at around 1%. And it was higher in breast cancer, lung cancer, prostate cancer, colon cancer, and lymphoma specifically. Then the major bleeding remained at about 4.5% in 2003 and went all the way up to 15% in 2015. And it was specifically high in the subgroups of breast cancer and prostate cancer. The stroke rate remained at about 0.9% in 2003 and went up to 1.5% in 2015. As expected, the stroke and bleeding rates are much higher in metastatic cancer. So Dr. Addison is now going to tell us about sort of what it means for clinical practice.
Thank you, Dr. Guha. These data that we present are important for clinical practice here in the year 2020 and beyond. These data do suggest that CABG still is a viable option, as noted, but that even within this, in the contemporary setting, strategies for complex coronary disease, including complex PCI and CABG, still remain viable options and may actually be best amongst patients who have or meet appropriate criteria for these potential surgical or invasive interventions. However, despite this consideration, it is important to note that there may be a generally increased risk of bleeding amongst these patients. Despite this, CABG still remains a viable option amongst cancer patients expected to live a reasonable amount of time.
So I think those are very important points Dr. Addison mentioned. And I think the next steps in this research is to sort of have a deeper dive with more granular data to see which will be those patients. Because I mean, obviously, there are papers that say that since CABG is going down, PCI is going up in cancer patients, but why? And which patients are these the best suited procedures? Obviously, for any analysis, the right thing to do is to study a prospective cohort and go forward rather than look backward once you have this kind of data already available, which we have now. And then we are hoping that this changes the practice in terms of how we do research. We should expect to like enroll more cancer patients in trials for revascularization, because as we know, and we have shown in our previous papers, that overall cancer patients are enrolled less in some of these cardiovascular trials. And then finally, just to sort of let everybody know that, no matter what disease you have in the past in terms of what cancer you had, this is a very viable option for you for revascularization if you have coronary artery disease. But I think those are the next future steps.
Well said, Dr. Guha. Well said. I think for our time in these times, this is really our best answer going forward. And the call for more prospective, inclusionary research and clinical care is really our best bet going forward.
Thank you so much for listening. I hope you enjoy reading this article and learn a lot more about the practices of coronary artery bypass grafting in the United States in the cancer patient. We welcome some questions and comments in the comments below.
I'll only add an echo to that sentiment. Thank you again for reading this manuscript. This really was the culmination of work over the last 2 years. We're hopeful that it may help many patients going forward. And thank you. Please gain all the knowledge you can for this rapidly growing patient group.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.